Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Wolf Petersen from Berlin, Germany. Professor Petersen is the director of the orthopedic department at the Martin Luther Krankenhaus in Berlin, the academic hospital of the Charité. He specializes in sports trauma, osteotomy, and arthroplasty, and is certified by the German Knee Society. He's the past president of the German Knee Society and also the vice president of the German Sports Trauma Society, also serves as their board member. He's also the chief editor of the Knee Journal and serves on the editorial board member of Operative Orthopedics and Traumatology, Arthroscopy, and the Journal of the AGA. He has published widely and has more than 400 PubMed listed scientific publications. If you've noticed, Professor Petersen has delivered several lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Professor Wolf Petersen for this wonderful live program. Over to you, Professor.
Yeah, thanks so much for this wonderful introduction. I'm looking forward to this program, and I congratulate you for establishing this great program to make surgical education available for many people all over the world. So let's focus today on the medial collateral ligament, which is in my opinion, very interesting topic. But first, I would like to invite you to a meeting, to a face-to-face meeting here in Berlin, the International Knee Days 2027. So there's a lot of time to save the date, and I'm really looking forward to meet you in Berlin, April 28 to April 30th. 2027. Okay, today, and these are some codes if you're interested in more educational content. These are our Instagram channels, the channel of the International Knee Academy. You will find several reels or posts about all topics around the knee joint, and on the right you can see my personal account where I post most of my scientific or professional activities. Yeah, so the presentation is divided in 3 parts. A very short introduction about anatomy of the medial collateral ligament and the medial collateral ligament complex, because the anatomy is the basis for all repair techniques. Then we will discuss acute injuries and last but not least, chronic instabilities. Yeah, let's start with this nice anatomic picture. So the 3 main components of the medial collateral ligament or the medial ligamentous complex is the superficial medial collateral ligament with the insertion here around the medial epicondyle, and then it runs downwards and inserts here below the pes anserine, approximately 7 to 8 centimeter distally of the joint line. Then we have the posterior oblique ligament, the POL, which runs in an oblique direction here also from the posterior aspect of the medial condyle to the proximal posterior part or posterior quarter of the medial tibia. And then the deep MCL, which has also an oblique direction and runs here from the epicondyle to the anterior aspect of the proximal tibia. Here another drawing. You see some additional structures here, but the POL, the SMCL, and the DMCL again. But here you can see also the posteromedial capsule, which is here in the posterior part, and the coronary ligament, which is the ligament between the medial meniscus and the proximal tibia. And this is important when we discuss about ramp lesions of the medial meniscus. But this is also a part from an anatomical standpoint. This is also a part of the medial collateral ligament or the medial ligamentous complex. And here on the right, you see in this table each structure and also the function. So the superficial medial collateral ligament is the main stabilizer against valgus rotation. The posterior oblique ligament is a secondary stabilizer against posterior tibial translation, but this is the main function of this ligament, but it's also a secondary stabilizer against valgus stress, especially in extension. And the deep medial collateral ligament, or some authors also call the structures anterior oblique ligament. This is a main stabilizer against anterior tibial translation, but also against valgus stress and also external rotation. And these functions are quite important when we talk about the indication for surgical reconstructions and when we talk about diagnostic of these injuries. Here you can see a schematic drawing. You can see here also all the ligamentous structures. And you can see here in this drawing how these structures stabilize against rotational stress. When we talk about injury, it's important that we can classify these injuries. This is a very old classification, the Houston classification, which is further development of a classification from the American Medical Association. It was developed in '66, so it's a quite old classification. So these classifications classify MCL injuries in 3 different grades. Grade 1, which is a stretch injury, or few fibers of the MCL are torn. Grade 2 is an incomplete or partial MCL tear. Here you can see a schematic example in the middle. And the grade 3 is a complete MCL tear. So these are the clinical findings of these injuries. So in the grade 1, we have a firm endpoint with no laxity. In the grade 2, the moderate injury, we have a firm endpoint, but mild increase in knee joint laxity. And the grade 3 is characterized by no endpoint and excessive joint laxity. When we look to basic research, Xavier Wu has shown in the 80s already that the medial collateral ligament has a good healing potential. And then several clinical studies have also shown that isolated MCL injuries have a good healing potential, and even injuries in combination with an anterior cruciate ligament like Shelburne here or Hillert-Zembel, or by myself, I did also a clinical study during my residency at the end of the 90s. So in all these studies have shown that for grade 1, 2, and 3 MCL injuries, there was no difference between operative and non-operative treatment of the MCL. And this was true for isolated MCL injuries and also for combined ACL MCL injuries. But the question is now, is this really true? Do we really need no surgery for our collateral ligament injuries? And when we look to this MRI, you see here an injury of the MCL. You see the typical wave sign here in the proximal part. Here you see the pes anserine. And here you can see that the distal stump of the MCL or of the SMCL slipped above the pes anserine. And these lesions are called Stener-like lesion, like at the thumb. And yeah, there's a lot of agreement in the literature that these injuries should be operated because the pes anserine inhibits the distal stump from contact to the bone. So these lesions have a poor healing potential. Here you can see the wave sign, the stump, and this is the pes. Here you can see an image from the operating room. Here's the pes, the hamstrings tendons, the gracilis, and the simiti. And here the medial collateral ligament stump, as you can see it here on this schematic drawing, slipped over the pes anserine. So there's general agreement that these injuries should be repaired. I show you a repair technique here with this schematic drawing. I use an anchor technique. I insert the anchor in between the gracilis and the simiti tendon. Then you have to shuttle the threads of the anchor, or one thread of the anchor below the gracilis tendon. Then you have to reinforce the tendon stump, and then you have to shuttle the tendon or the thread back below the gracilis tendon, and then you can tie the knot here at the anchor and close the fascia between the gracilis and the simiti tendon. This is a nice technique, and yeah, Thompson and co-workers, they have shown that surgical repair of acute Stener-like lesions is associated with a high return to sport in active patients. And Grassi, Alberto Grassi, I've shown the study on the previous slide. He has also published a systematic review and meta-analysis and has shown that surgical treatment of those lesions has a very good surgical outcome. Here you can see the Grassi study. It was a systematic review. So, and when we look to this registry study from the Swedish National Knee Ligament Registry for Primary ACL Reconstruction, this was a study about approximately 20,000 patients, and they found that non-surgical treatment of an concomitant ACL injury in the setting of an ACL reconstruction may increase the risk of ACL revision. So, yeah, maybe there is some indication, also some other indications for surgery for ACL, MCL lesions. However, in this study, treatment of the MCL injury was associated with the worst 2 years patient-reported outcomes. So I think there should be a shared decision if the MCL is treated operatively based on the MCL injury type. So I think these Stener-like lesions qualify an MCL injury for surgery, but yeah, maybe some other factors. So when we look to these grade 3 injuries, maybe in the past, all these studies by Shelburne, Hillard, Zembel, and also by myself included just these grade 3 injuries. So and these grade 3 injuries are characterized by a complete tear of the SMCL, but the posterior oblique ligament and the PMCL were maybe intact. So that means that maybe in full extension, the valgus laxity was not so severe, but in 20 degree of flexion, these patients had a severe valgus instability. But these injuries are also grade 3 injuries, so injuries, complete tears of the SMCL, the POL, and the PMC. And maybe these are injuries which need surgery when you detect these injuries by clinical examination and on your MRI. So maybe we could develop this algorithm so all these grade 1 and 2 injuries can be treated non-operatively. I think there's general agreement. And maybe for the grade 3 injuries, these isolated injuries of the SMCL could also be treated non-operatively with a brace for 6 weeks maybe. But when we have proximal avulsions and when we have more than 2 medial structures injured, maybe the SMCL and the POL and maybe the posteromedial capsule, then we should also go for repair. The same is true when we have a Stener-like lesion, or the next or the last entity is a knee dislocation. In this case, a knee dislocation 3M with injury of the SMCL, POL, and PMC, and additional injury of the cruciate ligaments. And these injury require surgical therapy of the knee dislocation. So this is an example. I will reduce this. So here you can see the posterior draw in internal rotation. This patient has also a posterior draw in neutral rotation, but in external rotation, the draw was less. And here you can see the MRI. So this is a typical MRI finding of a type 3 shank, shank type 3M knee dislocation. And I think these injuries also require, here you can see the valgus laxity, and here's a posterior draw in internal rotation, which shows that the posterior oblique ligament is injured. In addition to the PCL injury, the posterior draw in neutral rotation, but more stability in external rotation, which shows that the posterior lateral complex is intact. So this is a typical examination of a grade 3M knee dislocation. Here's another example. You can see an example of a complete proximal avulsion of the POL and the SMCL, as you can see it here in the schematic drawing, but this patient had also an avulsion of the MPFL, which is very close to the insertion of all the other medial ligamentous structures, and the injury mechanism, the valgus trauma, is also a typical trauma for the MPFL injury. So in this case, this would also be an ideal indication for repair. I use an anchor repair for these cases. And here's another case of a severe shank 3M knee dislocation with a complete disruption or complete destruction of the medial structures, the medial ligamentous structures, but also a rupture of the or injury of the patella tendon. So in this case, we started here with refixation or repair of the coronary ligament and the DMCL. This is the SMCL, and the SMCL is later fixated here. And then, as you can see it here you can see the SMCL repair. Here's the PES, and the patella tendon was still injured, and here you can see the repair of the patella tendon and the ligament bracing of the patella tendon. So regarding the types of injuries, I divide the avulsions, distal avulsion, Stener-like lesion or proximal avulsion from the interligamentous injuries. And this is just my clinical experience. The healing potential of these avulsions is much better than the healing potential of the intraligamentous injuries. Here you can see the destruction of the ligament, and here is the typical bone bruise pattern on the lateral side. And in my personal experience, the healing potential is much better when we have proximal or distal avulsion. Therefore, in most cases, in these injuries, an anchor repair is possible. And in these intraligamentous injuries, you have to decide based on the tissue quality, based on the extent of injury, of destruction, if you need or if you need to augment your repair, your suture with a ligament bracing, with a suture tape, or even a ligament bracing with a graft, even in the acute setting. So regarding repair techniques, we differentiate the refixations with a suture anchor or rigid anchor. This is a soft suture anchor. I prefer these soft anchors. The indications are avulsion injuries, and then we have the suture techniques, and then you can decide if you have to augment these suture techniques with an internal brace, either internal brace with suture material as shown here in the schematic drawing, and the indication are intraligamentous injuries, but if you have a severe destruction, like in this case, you can also take a graft for a ligament bracing to augment the repair in the acute setting. So this is my algorithm for for the treatment of acute injuries. So these are if you have a knee dislocation. This is for acute multiligamentous injuries. If we have a knee dislocation, it's very important that you do vascular and neurological diagnostics. In the medial-sided injuries, we only rarely have neurological complications. These are more frequent for lateral injuries, for the varus trauma, but you should always look for the neurological status. But you have to check for vascular injury. Then you have to treat the vascular injury. If we have no vascular injury, then we should do an MRI. And when the MRI shows a peripheral medial injury, if we have a bony avulsion, then we should go for an anchor repair. And if we have just a peripheral interligamented injury, we should do a suture repair and combine it with bracing, either with ligament or with suture tape. So when we look to chronic injuries, in some cases, especially in these vascular cases or in polytrauma cases, we cannot prevent that an acute injury becomes chronic. We have also some treatment failures. But when we are in this stage, more than 6 weeks or maybe more than 12 weeks, and the patient still has instability symptoms, then we should go for a reconstruction technique. And I will start with a short classification of reconstruction techniques. So the first reconstruction technique for chronic injuries is the plication technique. This plication technique is a PUL advancement, or it was also called Houston technique in the past, because it was described by Houston in the beginning of the 70s. And the next technique is the tenodesis technique. And the first tenodesis technique was described by Martin Lind at the end of the 0 years. And for this tenodesis technique, Martin Lind took the pediculated semitendinosus tendon. The distal insertion was left intact. So that's why the insertion of the ligament reconstruction was a little bit more anterior compared to the normal insertion, which is quite in the middle of the proximal tibia. And then the loop of the tendon was inserted in a tunnel, which was or is here around the medial epicondyle. And the second strand of the loop was used to reconstruct the posterior oblique ligament. Last year or this year, Lind and Kittel published a modified Lind technique. It was an anteromedial tenodesis technique using also the ipsilateral semitendinosus tendon. So the first strand should reconstruct the AOL or the DMCL, and the second strand should reconstruct the SMCL. So it's, in my opinion, a non-anatomical reconstruction technique. And one disadvantage, in my opinion, is also this technique used the ipsilateral hamstring tendon or the ipsilateral semitendinosus tendon. And we know from a study of Mirko Herbert, and I was also co-author of the study, that the medial hamstring tendons have play an important role for stabilization against varus rotation. I will show you this study later. Then the next technique is the reconstruction technique. So this is a reconstruction of the SMCL. You can use several tendons for these reconstruction techniques: the semitendinosus tendon from the contralateral side, the peroneus tendon split graft, or the rectus femoris tendon. And here you drill a blind tunnel in the area around the medial epicondyle, and here distally at the tibia, and you reconstruct the SMCL. Then we have the posteromedial reconstruction technique, where you reconstruct the SMCL and the PUL. And the indication here is the posteromedial instability. It's a quite anatomic technique, and you can protect the ipsilateral hamstrings. So this technique has also disadvantages. So you need some implants, so it's more expensive maybe compared to the tenodesis technique. And last but not least, the anteromedial reconstruction technique. And the indication here is the anteromedial instability. It's also an anatomical technique, and you can also protect the ipsilateral hamstrings. And the disadvantages were or are the same as for the POL reconstruction technique. So in my clinical practice, for the chronic instabilities, I prefer the reconstruction techniques, the anatomic reconstruction technique. The anteromedial for the anteromedial instabilities, and the posteromedial for the posteromedial instabilities. In only rare cases, I just concentrate just on the medial or in the SMCL, because in most cases we have combined anteromedial or posteromedial instabilities. And the main advantage of this technique is protection of the ipsilateral of the ipsilateral hamstrings, because in this study, Mirko Herbert has shown that the ipsilateral hamstrings are active medial stabilizers against varus rotation. Therefore, the conclusion of this study was the ipsilateral hamstrings should be preserved in case of medial instability. So graft choice, today we have a lot of graft choices. For medial reconstructions, we need long tubular grafts. You can still use these tendons for your ACL reconstruction, or PCL reconstruction. As I told you, in most cases, there are combined instability, and that's why in most cases I use the medial reconstruction technique in combination either with an ACL reconstruction or with a PCL reconstruction. But for the medial side, you need long tubular grafts. The rectus femoris is the long tubular graft. The semitendinosus tendon from the contralateral side, of course, or the peroneus longus split graft is also a very nice tendon for medial reconstructions. So this is an interesting video. I did it by myself in an arthroscopy course in Utrecht last year. And yeah, here you can see we did in this cadaver course a selecting cutting study. Here you can see the DMCL. This is the SMCL. And here in this sequence, I distally cutted the SMCL. You can see how the rotational instability increased, and with further cutting of the DMCL, the rotational instability further increased. And when we reconstructed the DMCL and the SMCL with these tendon grafts, I can show you the video again. Here you can see the complex intact. This is a DMCL. This is a SMCL here, DMCL. And then we dissected the SMCL, as you can see it here, with increase in rotational laxity, increase of resection of the DMCL or transection of the DMCL, and you can see a further increase of rotational laxity. And here you can see how you can restore the stability of the joint with reconstruction of the DMCL and the SMCL. This is an picture from the OR with an SMCL graft and the DMCL graft in place. By scanning the QR code here, you get access to my YouTube channel, and you can watch a video of the whole surgical technique. And I think there is definitely more research needed about optimal indications for anteromedial reconstruction and maybe for further development of the surgical technique. So today my indication criteria are a positive rotational Lachman test. As you can see it here, you can see more laxity on the medial side compared to the lateral side. Or a positive dial test, as you can see it here in this photo. And some MRI signs would be a more laxity or more static laxity on the medial side as compared to the lateral side, especially here when you see this anterior gapping in the medial compartment. So Vera and co-workers, they established an anterior grading system, which is also based on this anterior draw, as I have shown you, the dial test, and also results of the various stress tests. So a grade 1 injury is anterior medial draw plus external dial test plus various stress test negative. And this is an isolated injury of the DMCL. I think these injuries have a good healing potential. But in my clinical practice, I think, especially in these grade 3 injuries with a 3+ anterior draw, anteromedial draw, and then 3+ external dial test and a positive vagus stress test, are injuries of the DMCL, SMCL, and ACL, and these injuries, I think need surgery. So this is another case with the chronic Posteromedial instability. Here you can see the draw of a positive 3+ or 3+ positive draw in internal rotation and neutral rotation. Here you can see the vagus stress test, which is definitely positive also here in the stress X-ray. This was a medial joint space of approximately 15 millimeters. And you can see here the posterior draw in the stress X-ray, and this is a posterior draw of more than 15 millimeters. And if you have a posterior draw of more than 12 millimeters, that is an X-ray sign for additional injury of the posteromedial or posterolateral structure. So in this case, it was the posteromedial side. So for me, I did a PCL reconstruction in this patient and a posteromedial reconstruction. For the posteromedial reconstruction, I use an open approach from the medial epicondyle distally to the hamstring tendons. We published this study in the arthroscopy technique. So by scanning this QR code, you can get access to this study, which is a technical description and a video. Then you have to drill 3 blind tunnels, one in the area of the medial epicondyle, one in between the semitendinous and gracilis tendon, and one here at the last or most posterior quadrant of the proximal tibia. Then you have to insert a 2-stranded graft. One graft strand is for reconstruction of the SMCL, and one graft strand is for reconstruction of the POL. And so here you can see the tubular grafts in place, but you know from the anatomy that the MCL has not a tubular shape, but it has more a flat shape. That's why I always try to suture the edges of the tubular graft strands to the MCL remnant to like iron the tubular graft to flat graft strands, as you can see it here in the schematic drawing, or here in the schematic drawing, to reproduce the flat structure of the medial ligamentous structures. So in conclusion, acute injuries, acute grade 1, grade 2, and isolated SMCL injuries can be treated non-operatively. Stener-like lesions, complex grade 3 lesions with injuries of the MCL, POL, and PMS should be treated by surgical repair. For avulsions, I use a suture anchor repair. For interligamentous injuries, suture of the repair of the injured structures combined with the ligament bracing, or even with the graft in severe cases. For chronic injuries, I prefer reconstruction technique with an allo or an autograft. And the graft choice is ipsilateral hamstring should be avoided. Long tubular autografts are needed for these reconstructions. Semitendinosus, contralateral peroneus longus split graft, or rectus femoris graft, or tubular allografts. And for anteromedial instability, anteromedial reconstruction technique, one SMCL bundle and one DMCL and AOL bundle. And for the posteromedial instability, posteromedial reconstruction, one SMCL bundle and one POL bundle. Thanks for your audience.
Thank you very much, Prof. Prof, any more slides? That's it, right?
Yeah, that's it. Thank you. Thank you so much.
Thank you very much, Prof. Prof, you can stop sharing. Yeah, you can close the PPT. Yeah. Thank you very much, Prof, for this yet another comprehensive and extensive presentation on MCL. And thank you for all the links that you uploaded. So if someone wants to watch more surgical techniques, they could go and watch it on your channel. Prof, just a few questions. The addition of the POL, the POL reconstruction is indicated only if you have a posteromedial instability, right?
Yes.
And what is the clinical test that differentiates between an anteromedial instability and a posteromedial instability? What is that critical thing where you need to add a POL reconstruction?
It's I mean, if you see severe injury in the MRI, you get an impression. So if you have, for example, an additional PCL injury, it's definitely an indicator for dealing with the POL. But in the clinical examination, when you do the posterior drawer in internal rotation, and if the knee is lax or more even more lax than in neutral rotation in internal rotation, then this is definitely a sign for severe POL injury, and then you should address the POL.
So, suppose if in an MR he reports a grade 3 MCL, that is a complete tear, do you think a routine POL reconstruction is necessary?
I mean, no, it depends on the additional PCL or
That's it.
ACL injury. If I have a posteromedial instability, and in most cases, the isolated MCL or valgus instabilities are very rare. So in most cases, they are either combined with a posteromedial corner injury and combined with a PCL, or an anteromedial instability combined with an ACL. So yeah, so in most cases, these injuries are a little bit more complex.
Prof, I just wanted to go through the Martin Lind's paper, right? In 2009, Martin Lind's paper, he reconstructed the POL, whereas the latest version, I think the POL is absent, right?
Yes, because they modified this technique especially for anteromedial instabilities. But I think the positive thing of the Lind technique was, and because when you look to the Lind paper, you see that that Lind included, I don't know the exact numbers, but I think he reported 60 injuries, and he had I think 25 or 30 anteromedial instabilities, and the technique worked also for the anteromedial instabilities. And I think the reason is because he restored the insertion of the symmetry. And yeah, that's why the vector was a little bit more anterior than the normal SNC-MCL insertion.
And
And
yeah.
and by reconstructing the SMCL also stabilized against anterior tibial translation. So that's why I think this technique always worked also for anteromedial instabilities.
And Prof, do you use the hamstrings or you take the other grafts?
I try to preserve the ipsilateral hamstrings, and because it's more demanding to go to the other side because you have to drape two legs, so it's a little bit more complicated. I prefer to stay on the same leg than take the peroneus longus or the rectus femoris.
Professor, any tips for the rectus femoris?
Yeah, it's definitely different from the quadriceps tendon. You have to start a little bit more proximal. With the quadriceps tendon, you start with your harvesting, yeah, quite at the proximal patellar pole. It's a transition between bone and tendon. For the rectus, you have to make your incision in between the lateral and middle third of the patella. You have to go a little bit more laterally, and it should be 3 centimeters above the patella, the proximal patellar pole, in the area of the fuse zone between the rectus tendon and the rest of the tendon, which is 2 to 3 centimeters proximal of the insertion of the quadriceps tendon at the patella.
And you can do
And
it with a small incision, or you like
I,
to use a
I do an incision of maybe 3 centimeters, sometimes 4, to get a good exposure. Then I do a parallel, then I open the fascia. Then I do 2 parallel incisions of approximately 10 centimeters. Then you can separate the rectus with a clamp. And when you have saved the rectus femoris, then you can continue with the preparation a little bit more distally to increase the size or the length of the graft. But you should start, you should not start this study. I did it in one of my first cases in the cadaver lab. I did this, but then Sergio Canuto from Brazil showed me the exact technique, and yeah, and now it works.
And you use the same tendon stripper, the standard one,
Yeah. The normal, yeah, the 9 mm tendon stripper.
the normal stripper.
Yes. But a little bigger stripper should be advantages.
Thank you, Prof. And Prof, there's a question that has come up on our YouTube channel, whether you would like to go for repair versus early repair in a multi-ligament knee. Of course, he would have meant the medial side. Or versus repair versus reconstruction.
In the acute setting,
Yeah.
I prefer repair. But yeah, some well-known surgeons, for example, Bertrand Sonnery-Coté, they prefer reconstruction. I think you can get very good results with repair, but we have also some failures. I think with repair, I have always a second choice with my tendons, because we also see some failures, maybe a little bit less frequent with reconstruction techniques. So my personal choice is repair, and Karl-Heinz Frosch and his group here from Germany, from Hamburg, they performed a multi-center study and showed very promising results with this repair technique. And yeah, several other surgeons like Eduardo Monaco from Roma, or Gregory De Fellis from New York, they also prefer a repair technique. So I think for the acute injuries, we should continue with repair techniques.
And can we make a statement that tibial avulsions respond well to repair
Definitely.
compared to femoral and mid-substance tear, because you get that thick fleshy part of the tibial avulsion and repair is much easier, right?
Definitely. I think, and this is what is, as this is my personal experience, but this is also what the systematic review of Alberto Grassi has shown. The distal avulsions have a very good repair potential when you do just a refixation with the suture anchor.
Thank you, Professor. Professor, I think that's all the questions that we have for the session. Thank you for this wonderful talk and absolute brilliant surgical techniques. I would recommend all the viewers from different parts of the world to visit your channel. I personally see a lot of your videos and actually before operating, and that makes your surgery much easier. And I also request all the viewers to participate for the International Knee Day for 2027. And we're going to have more programs for the meeting.
Yeah, thank you so much for this invitation. It was wonderful as always, and I hope to see you in Berlin.
Thank you very much.